Episode 16, Proximal Control, Vascular Surgery, Exam Prep. Carotid and Vascular Artery Disease. FRCS and European Board Vascular Surgery Exam Focused Teaching. Welcome back to Proximal Control. I'm your host, Mo Mia. This is the podcast where we prepare for the vascular exams the same way we practice as a day one consultant, with structure, judgment, and control. Because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. This episode is designed to be a high-yield revision script of the atherosclerotic carotid and vertebral artery disease along with various trials. So I will keep it structured and exam focused. Let's start with carotid disease. And at the beginning, we will go through a few important definitions. Let's start with TIA. TIA means a focal brain, retinal, or spinal cord dysfunction lasting less than 24 hours of non-traumatic vascular origin. Whereas stroke means sudden onset focal neurological dysfunction lasting more than 24 hours or causing death in less than 24 hours, again of non-traumatic vascular origin. Crescendo TIAs means multiple TIAs in a short time period, commonly defined as more than 2 in 24 hours or at least 3 in 7 days. So if you think carefully, more than 2 in 24 hours, which means more than 2 means 3. 3 in 24 hours or at least 3 in 7 days is the same thing. We can say 3 in 7 days. It could be within 24 hours, could be within 48 hours. As long as 3 in 7 days, that's a crescendo TIA. And very importantly, there will be full recovery between episodes. If it does not recover between episodes, then it will be called as stroke in evolution. So, stroke in evolution means a fluctuating or progressively worsening neurological deficit without full recovery. And for you to know, crescendo TIAs and stroke in evolution are the two emergency indications for carotid endarterectomy. These are really important thing to remember. So, crescendo TIA recovers between attacks and stroke in evolution does not. Why carotid disease matter? The main cause of carotid territory ischemic stroke include thromboembolism of the ICA and or middle cerebral artery up to 50%, small vessel occlusion up to 25%, cardiac embolism only up to 15%. The aim of primary prevention is to reduce the impact of asymptomatic carotid stenosis and vertebral artery stenosis before TIA or stroke happens. The aim of secondary prevention is to prevent recurrent TIA or recurrent stroke or other vascular events in patients who have already presented with symptoms attributable to carotid or vertebral disease. Now, what are the symptoms of carotid versus vertebro-basilar disease? The ESVS guidelines include a very useful table summarizing territory-specific symptoms, and this is exactly the kind of thing that you need to remember. The carotid territory symptoms, think about higher cortical dysfunction like aphasia, dysgraphia, apraxia, visuospatial problems, visual field deficit, or amaurosis fugax or transient monoocular blindness, chronic ocular ischemic syndrome, weakness or sensory loss involving face, arm, or leg, upper or lower limb clumsiness, limb shaking TIA in severe hemodynamic disease with exhausted reserve. This would be the carotid territory symptoms. Now, if we talk about vertebro-basilar territory symptoms, think about complete visual loss or blurring or hemianopia, diplopia or ptosis, vertigo, but usually with other brainstem symptoms, acute sensory neural hearing loss, dysarthria, dysphasia or dysphonia, bilateral facial or limb weakness or numbness, and then ataxia. So these are vertebral or vertebro-basilar territory symptoms. So carotid gives cortex and eye symptoms. Vertebro-basilar usually gives brainstem, balance, and bilateral signs. Now let's talk about the carotid stenosis. How would you measure them? We all know that there are NASET, there are ECST for measuring the stenosis. If we talk about NASET uses the normal distal ICA as the denominator. Having said that, if the distal ICA is not normal, i.e. maybe aneurysmal, then you cannot use that as a denominator. That means you cannot use NASET. Okay, what about ECST? ECST uses the estimated original diameter at the carotid bulb as the denominator, which means you can understand that the bulb diameter will be wider or larger than the distal ICA diameter, obviously. That means the ECST stenosis grading will be higher than the NASET because it uses higher, larger diameter as denominator. So, a 50% NASET will give you a 70% ECST, and a 70% NASET will give you an 85% ECST. So ECST always looks more severe than NASET. Now, as we already mentioned, where NASET becomes unreliable, you can now say, if you do not have a normal distal ICA to use as a denominator, then you cannot use NASET reliably. Such as if you have distal ICA collapse or near occlusion, or situations where there is no normal distal reference segment, such as aneurysmal ICA. And that is why in near occlusion, descriptive reporting and recognition of distal collapse matter more than quoting a standard NASET percentage. This is highly exam relevant. Now let's talk about some imaging strategy. The ESVS guideline supports duplex ultrasound as first-line imaging in most patients, with CT angiogram or MR angiogram to confirm anatomy, clarify uncertainty, plan intervention, or evaluate beyond the accessible cervical carotid segment. The multidisciplinary team is important throughout. So, duplex as the first line, as it is accessible, non-invasive. CT angiogram, excellent anatomy, it is fast, good for planning. MR angiogram is useful alternative of CT. And DSA, not routine, reserved in selected circumstances, such as if the patient is going under carotid stenting or interventions. For carotid stenosis, contrast enhanced MRA, which is CEMRA, has the highest sensitivity and specificity. That is 94% sensitive and 95% specific, and least heterogeneity, followed by duplex ultrasound, which has 89% sensitivity and 95% specificity. That means specificity is the same in duplex ultrasound and contrast enhanced MRA. However, contrast enhanced MRA is more sensitive, that is 94%, than duplex ultrasound, which is 89%. Okay, duplex ultrasound velocity criteria. This is really important for you to remember in the exam. It can come as a part of the question stem showing you a PSV for you to guess the stenosis grading, or it could be in an ultrasound scan imaging at the corner of the picture where it will be mentioned the PSV is such and such or so and so. So you need to guess, or you need to identify the stenosis grading for you to know whether you intervene or not. So NASET based duplex velocity criteria is really important in exam. And the key to remember, it is not memorize every number. It is not to memorize every number in isolation. The key is to build a simple ladder in your head. Let's do it together. So if you think about less than 50% stenosis, you need to remember three numbers. PSV less than 125, ICA-CCA ratio less than 2, and St. Mary's ratio less than 8. For you to know what is St. Mary's ratio, St. Mary's ratio is ICA PSV divided by ICA EDV. That is PSV by EDV in ICA. That's your St. Mary's ratio, okay? PSV is the peak systolic velocity and end diastolic velocity is the EDV. So PSV by EDV in ICA is the St. Mary's ratio. So you compare these two velocities, but it's both in ICA. Whereas the normal ratio that we talk about is the ICA and CCA PSV ratio. But this is only the PSV, but you compare ICA divided by CCA. And that's the ratio that we keep talking about, ICA-CCA ratio. Okay, let's do it again then. Less than 50%, you need to remember three numbers. Less than 125 PSV, ICA-CCA ratio less than 2, and St. Mary's ratio less than 8. Okay? Three numbers, less than 125, less than 2, and less than 8. Okay, now 50 to 69%. Again, three numbers, 125 to 230, ratio 2 to 4, St. Mary's 8 till 13. Okay? Three number, 125 to 230. Well, I'll say 125 to less than 230. And ratio 2 to 4. Of course, less than 4. St. Mary's 8 till 13. Okay? Now, more or equals to 70% stenosis. If it's more or equals to 230, or if it's more or equals 4, or St. Mary's if it is more or equals 14 up to 29. Okay, so again three number, 230, 4, 14 till 29, yeah? 230 for PSV, ICA-CCA ratio 4, and St. Mary's 14 or more. That is your more than 70% stenosis. Okay, what about more than 90% or severe stenosis? Then you will have a PSV more or equals to 400, ICA-CCA ratio more or equals to 5, St. Mary's ratio more or equals to 30. So three numbers again, 400, 5, and 30. That gives you more than 90%. So let's just only talk about the numbers now, starting from less than 50%. 125, 2, and 8. 50 to 69. 125 to 230, 2 to 4, 8 till 13. More or equals to 70%. more or equals to 230, more or equals to 4, and more or equals to 14. So if you think about 50 to 69%, just more than the last digit is more or equals to the last digit is more than 70%. Okay. Now we talk about again more than 90%. Three numbers, 400, 5, and 30. 400, 5, and 30. That's so easy, right? Let's go to near occlusion. What will happen to near occlusion? The PSV will be variable. It could be high, it could be low, it could be a string flow. Okay. Now let's talk about the occlusion. Well, there is occlusion means no flow. So don't have to worry about any PSV. There will be no flow. So if you say an occlusion, no flow, if it is variable, one point is high, one point is low, and then it's string flow, it is near occlusion. Okay? Now, one-line exam recital, if you want to remember them clearly, that's 125 to 8, 234 14, 405 30. That's it, right? Let's do it again. 125 to 8, 234 14, 405 30. That's your exam recital line. Remember, this is really high yield, and that's why I have repeated multiple times. Now, there is an exam caveat for you to remember. Duplex is reliable for carotid stenosis grading, but CT angio or MR angiogram sometimes is necessary if there is uncertainty, there is poor window, or proximal or distal disease suspected. Then you have to go for CT angiogram or MR angiogram. Now let's talk about asymptomatic carotid stenosis. What does the guideline say? The ESVS guideline puts best medical therapy first for asymptomatic carotid stenosis. The role of intervention is selective, not routine. What best medical therapy in asymptomatic disease? This is almost pretty similar. That's lifestyle measures, antiplatelet therapy, lipid lowering, blood pressure control, diabetes management, medication adherence, and this is almost similar to symptomatic disease. What about screening? Routine population screening is not recommended. Selective screening may be considered in higher risk groups, but the guideline focuses on the harms of indiscriminate screening as well as the limited yield. When might intervention be considered in asymptomatic disease? This is really important. So the guideline retain the concept that 60 to 99% asymptomatic carotid stenosis. Remember the number. Here we're talking about 60 to 99 in asymptomatic carotid stenosis. Patients with one or more of the clinical or imaging features suggesting higher stroke risk despite best medical therapy. That may be considered for intervention such as carotid endarterectomy or stenting. But importantly, if you have a severe stenosis, 80 to 99%, but it's asymptomatic, this is alone is not a high-risk criteria for intervention. That means the grading severity is not the high-risk criteria. Okay. So, asymptomatic disease is medical first, operate only if selected, and genuinely high risk. The ESVS guidelines summarize the clinical and imaging criteria that identify asymptomatic patients who are high risk for stroke on the best medical therapy and therefore more likely to benefit from intervention. The patient should generally be fit to have an intervention should be expected to survive at least 5 years and have 60 to 99% asymptomatic carotid stenosis plus one or more high-risk features from the following, such as clinical feature, that is prior contralateral TIA or stroke, CT or MRI feature, ipsilateral silent brain infarction, ultrasound-based features, stenosis progression greater than 20% in between two scans, spontaneous embolization on transcranial Doppler, impaired cerebral vascular reserve, large plaque area over 80 square millimeters, ecclusion plaque, large juxtaluminal plaque area over 8 square millimeters, MRI-based plaque features such as intraplaque hemorrhage, large lipid-rich necrotic core. So, simply summarizing this, we can say we do not operate on asymptomatic stenosis just because it is there. We consider intervention in a fit patient with 60 to 99% stenosis, at least 5 years of life expectancy, and one or more features suggesting the plaque is stroke-prone despite best medical therapy, which are previous contralateral TIA or stroke, ipsilateral silent brain infarct on CT or MRI, ultrasound-based features such as stenosis progression by 20%, spontaneous embolization on TCD monitoring, impaired cerebral vascular reserve, large plaque area over 80 square millimeter, ecclusion plaque or large juxtaluminal plaque area or JBA over 80 square millimeter. MRI-based features such as intraplaque hemorrhage or large lipid-rich necrotic core. And these are exam safe. Okay, now we talk about symptomatic carotid disease. This is the high yield section. Now let's move to the most important part for symptomatic disease. The entire tone changes. Here, time matters, early recurrent stroke risk matters, and the role of intervention is much more established. Best medical therapy is the same as we discussed for the asymptomatic disease. Those are lifestyle changes, antiplatelets, lipid-lowering agents, blood pressure control, diabetes optimization, and adherence to the medication. But here there are major updates, especially around antiplatelet therapy. Antiplatelet therapy, one of the biggest updates is that the guideline has expanded best medical therapy, especially the role of combination antiplatelet therapy in recently symptomatic patients. If the patient is symptomatic and not undergoing carotid endarterectomy or stenting, the class 1 recommendation says aspirin plus clopidogrel for 21 days followed by clopidogrel monotherapy, or long-term aspirin plus modified release dipyridamole. If aspirin and clopidogrel cannot be used, dipyridamole monotherapy or ticagrelor monotherapy is recommended. If symptomatic patient is heading toward carotid endarterectomy, the guideline says neurologists, stroke physicians, and vascular surgeons should create a local protocol on whether to use monotherapy or combination therapy so as not to delay urgent surgery. Aspirin dosing around endarterectomy. Class 1 recommendation from ESVS guideline in symptomatic patients undergoing endarterectomy on aspirin monotherapy uses 75 to 325 mg, not high-dose aspirin. Dipyridamole option around carotid endarterectomy if aspirin and clopidogrel are not tolerated. Modified release dipyridamole 200 mg twice daily is recommended. Now, lipid-lowering agents. The guideline strengthens lipid management. If symptomatic carotid stenosis patients do not reach lipid targets on maximum tolerated statin, add ezetimibe 10 mg daily. Statin first, then ezetimibe. If target not reached, then consider more intensive lipid lowering where appropriate, such as PCSK9 inhibitors. Timing of intervention, one of the most important for the exam. The ESVS guideline devotes a major section to timing after symptom onset. The risk of current stroke is highest early, especially after TIA or minor stroke. Therefore, delaying treatment costs benefit. Carotid endarterectomy should be performed as soon as possible, ideally within 14 days of symptom onset in appropriate symptomatic patients, as per the ESVS guideline. The guideline discusses national registries and meta-analysis showing that endarterectomy remains acceptable in the early period, but very urgent intervention requires judgment, especially in unstable neurology or after thrombolysis. Best benefit comes from early surgery, especially within 2 weeks. Timing after thrombolysis. Meta-regression suggests that after intravenous thrombolysis, waiting about 6 days before endarterectomy should be considered so that the 30-day stroke or death risk stays within the accepted 6% threshold. After thrombolysis, don't rush straight to endarterectomy. 6 days is the key number from the guideline. What about tandem lesion and thrombectomy? The new guideline includes updated recommendations after mechanical thrombectomy, new Class 2B recommendation in selected acute stroke patients undergoing intracranial thrombectomy with a tandem 50 to 99% carotid stenosis and a small ipsilateral infarct. Synchronous carotid stenting may be considered. If antegrade ICA flow is poor or collateralization through the circle of Willis is poor after thrombectomy, this is very exam relevant because it shows the move towards tailored acute tandem lesion management. Now let's talk about some important trials in symptomatic disease, the ones you must quote. The ESVS guideline says that the pooled carotid endarterectomy trialist collaboration using remeasured NASET-based angiogram from ECST, NASET and Veteran Affair trial is the dataset we should quote rather than quoting old individual trials in isolation. Symptomatic carotid endarterectomy versus medical therapy. This is the most important table in the whole symptomatic chapter. Here's the simplest way to remember it. For less than 30% stenosis, endarterectomy gave no benefit. For 30 to 99%, the benefit was arrived. Absolute risk reduction only 2.7% and number needed to treat was 37. For 50 to 69%, benefit become meaningful but modest. 30-day stroke or death rate after endarterectomy was 8.4%. 5-year stroke rate was 20%, with endarterectomy versus 27.8% with medical therapy. Absolute risk reduction was 7.8%. So if we say again, 5-year stroke rate 20% with endarterectomy versus 27.8% with medical therapy. absolute risk reduction is 7.8%, and the number needed to treat was 13. Roughly 78 strokes prevented per 1,000 endarterectomies over 5 years. For 70 to 99%, benefit was strongest. 30-day stroke or death after endarterectomy was 6.2%. 5 years stroke risk was 17.1% with endarterectomy versus 32.7% with medical therapy, and the absolute risk reduction was 15.6%. Number needed to treat was only 6, so roughly 156 stroke were prevented per 1,000 endarterectomies were over 5 years. For near occlusion, there was no benefit, so the memory line is less than 50%, no real role, 50 to 69%, some benefit, 70 to 99%, clear benefit, near occlusion, no benefit. Now, carotid endarterectomy versus stenting in symptomatic disease. The guideline says both are options, but endarterectomy remains the benchmark in most symptomatic patients, especially in the early period. What do the trial shows? The guideline reviewed multiple RCTs and meta-analysis. The stenting has a higher early risk of stroke. Endarterectomy has lower peripheral stroke risk. Long-term ipsilateral stroke rates become much more similar after the perioperative phase. Age matters. Older patients do worse with arterial stent. The stenting has higher early stroke risk. Endarterectomy has lower periprocedural stroke risk. Long-term ipsilateral stroke rates become much more similar after the perioperative phase. So, age matters. Older patients do worse with carotid artery stenting. And the reason you all know that the arch of the aorta in elderly patients will be more calcified, and when you do wire manipulation around the arch, there is a high risk of stroke in this age group. So for elderly patients, stenting is not beneficial, or rather cause harm in the form of increased stroke rate. This is consistent with the major trials including CREST, ICSS, EVA3S, and SPACE. CREST, the composite endpoint broadly similar, and CAS had more stroke, CEA had more MI, but the stroke had a greater effect on quality of life than MI. So, endarterectomy is safer for stroke, and stenting trades stroke for MI. But stroke matters for quality of life. Now we'll talk about some trials in asymptomatic disease. Now we will talk about trials in asymptomatic disease. What you actually need to remember. The ESVS guideline says that although 5 RCTs compared endarterectomy plus best medical therapy with best medical therapy alone, only ACAS, which is ACAS, and ACST really influence practice. See, if we talk about ACAS, which is ACAS, 30-day death or stroke rate after endarterectomy was 2.3% only, and the 5-year ipsilateral stroke plus perioperative death or stroke rate was 5.1% with endarterectomy versus 11% with medical therapy. The 5-year any stroke plus perioperative death or stroke was 12.4% with endarterectomy versus 17.8% with medical therapy. The take-home message is ACAS showed a small but significant long-term benefit for endarterectomy. The take-home message is ACAS showed a small but significant long-term benefit for endarterectomy in selected asymptomatic patients. In ACST1, 30-day death or stroke after endarterectomy was 2.8%. At 5 years, any stroke plus perioperative death or stroke was 6.4%. At 5 years, any stroke plus perioperative death or stroke was 6.4% with endarterectomy versus 11.8% with medical therapy. And at 10 years, it was 13.4 for CEA and 17.9 for BMT. So, the simple spoken summary is ACST supported ACAS, again a small but real long-term benefit for surgery. So the simple spoken summary is ACST supported ACAS, again a small but real long-term benefit for surgery in selected asymptomatic patients. But the chapter is also very clear that these trials are now historical. Modern medical therapy has improved so much. The stroke rates on best medical therapy are lower than with those trials recruited. And the chapter gives the key evidence for that. In studies completed before 2000, ipsilateral spoken risk of chronic in institutes completed before 2000, ipsilateral stroke risk on medical therapy was about 2.3 per 100 person years. In studies from 2000 to 2010, it fell to about 1 per 100 person years. And in cohorts where more than 25% of patients were on statins, ipsilateral stroke risk was 1.2 per 100 person years versus 2.3 where statin use was lower. So the correct exam conclusion is ACAS and ACST support selected endarterectomy in asymptomatic patients, but their absolute benefit is smaller in the modern era because best medical therapy is much better. CAS versus CEA in asymptomatic disease. The guideline also summarizes a meta-analysis of 7 randomized trials comparing endarterectomy and stenting, around 3,467 asymptomatic patients. And again, the way to remember it is not every single cell but the pattern. Death at 30 days was essentially the same, 0.7% for both. Stroke was higher with carotid artery stenting. Death or stroke was also higher with stenting, that is 3.1% versus 2.1%. MI was actually numerically lower with stenting, that is 0.8% versus 1.8%, as it was not clear significant in the table. Death or stroke or MI was quite similar, 3.3% carotid artery stenting versus 3.1% endarterectomy. Let's talk about stenting versus endarterectomy outcome from the trial meta-analysis again. So death at all age was essentially the same in 0.7% for both, and stroke was higher, that is 3% versus 1.9% between stenting and endarterectomy. So stenting had 3% stroke and endarterectomy had 1.9%. Death or stroke was also higher in stenting, which was 3.1% versus 2.1% in endarterectomy, and MI was actually numerically lower in stenting, that is 0.8% versus 1.8% in endarterectomy. Death stroke MI was quite similar, that is 3.3% in stenting and 3.1% in endarterectomy. So, in asymptomatic patients, carotid artery stenting has a higher 30-day stroke and a death stroke risk than carotid endarterectomy. But once you get beyond the perioperative period, late ipsilateral stroke appears similar, so carotid artery stenting is durable but less safe early. This is exactly how to remember for the exam. Now, timing of surgery in symptomatic disease. This is important, and this topic reanalyze benefit by the delay of surgery and by sex. 50 to 69% stenosis, surgery within 2 weeks give ARR 14.8% and number needed to treat 7. At 2 to 4 weeks, ARR falls to 3.3% and number needed to treat was 30. After 12 weeks, benefit disappears. In 70 to 99% stenosis, within 2 weeks, absolute risk reduction was 23% and number needed to treat was 4, and benefit remains but falls with delay. But now let's talk about the difference by sex. For men, benefit in severe stenosis persists longer. For women, benefit drops off much faster. In women with 70 to 99% stenosis, the huge benefit is only really seen if surgery is done within 2 weeks. Beyond 4 weeks, benefit may disappear even in severe disease. In women with 50 to 69% stenosis, delayed surgery may actually give to benefit. So the summary is timing matters for everyone, but especially for women. The best benefit is within 2 weeks. Delays are particularly damaging in moderate stenosis or in women. Now let's talk about complication. Perioperative stroke rate is around 3% according to NVR data, and the death rate is around 1%. Restenosis in meta-analysis suggests that the average annual risk of current restenosis is 1.5 till 4%. So complications, the perioperative stroke risk is around 3% according to NVR data, and death rate is around 1%. Restenosis rate according to meta-analysis, the annual risk of recurrent stenosis is 1.5 to 4.5%, with the highest risk being in the first 12 months. 5.8% after endarterectomy in 47 months and 10% after endarterectomy in 62 months, and more than 70% restenosis after endarterectomy is significant but not after stenting. Restenosis, if it is symptomatic after endarterectomy or stenting, even if it is more than 50%, you consider endarterectomy or stenting. If it is less than 50%, you consider for medical therapy. And if it is asymptomatic after endarterectomy and it is more than 70% and any high risk feature in the MDT, then you consider for intervention. After carotid artery stenting, if it is more than 70%, still you consider only best medical therapy. Now, events during intervention or recovery within 6 hours. Carotid endarterectomy if ipsilateral neurological deficit with endarterectomy after flow is restored following carotid clamp release under loco-regional anesthesia. Immediate re-exploration consent form 4 of the carotid artery is recommended. If the general anesthesia neurological deficit might not be detected intraoperatively, carotid artery stenting, CAS acute stent thrombosis, while CAS treatment consists of intraarterial thrombolysis, aspiration or administration of intraarterial absciximab. In case where this did not resolve the occlusion in a timely fashion, conversion to surgery using either thromboendarterectomy with stent removal and patch closure or thrombectomy using aspiration after transverse arteriotomy of the ipsilateral common carotid artery. After intervention, after 6 hours, emergency re-exploration should be reserved for those patients who suffer an acute thrombotic occlusion after urgent CT angio to show intra or extracranial occlusion. Carotid artery stenting therefore does not seem to be the treatment of choice, and in emergency cases, mechanical removal has a theoretical advantage over thrombolytic therapy as it carries a low risk of bleeding. RTPA may be given as a 5 mg bolus followed by slow infusion within 3 hours. What is the procedure risk if we operate early? The Swedish registry showed a high risk if carotid endarterectomy done within 0 to 2 days, and that gave 11.5% risk. But after that, it fell 3% at 3 to 7 days, 4% at 8 to 14 days. And UK registry showed 3.7% at 0 to 2 days, 2.5% at 3 to 7 days, and 2.1% at 14 days. Germany was similar, 3% at 0 to 2 days, and about 2.5 to 2.6% thereafter. So, the memory line is endarterectomy in the first 48 hours may be riskier in some settings. CEA in the first 48 hours may be riskier in some settings, but after 48 hours, surgery within the first 7 to 14 days is generally safe and give the greatest long-term stroke prevention benefit. Now, neuromonitoring. We can use TCD ensuring shunt is working and mean MCA velocity remains more than 15 cm per second, and if it drops more than 50% from the baseline, then shunt is indicated. We can use EEG or sensory evoked potential. Once perfusion falls below 18 ml per 100 gram brain per minute, there is loss of high frequency activity on the EEG, whereas below 15 ml per 100 gram drain the brain per minutes, the EEG becomes isoelectric. Cerebral oximetry evaluates only perfusion in the superficial brain tissues. Now, CAS versus CEA in the symptomatic disease. Now, the other meta-analyses include 5,700 symptomatic patients from 10 RCTs. The key message is very clear. Compared with CEA, CAS had higher risk, higher deaths or stroke, higher death or disabling stroke, higher death or stroke or MI. But after the 30-day perioperative period, long-term ipsilateral stroke rates become similar, so carotid artery stenting was durable, just riskier earlier. The chapter then gives the practical predictors of worse carotid artery stenting outcomes. which are age over 70, carotid artery stenting within 7 to 14 days, plaque length over 13 mm, sequential or remote lesions, open cell stents needing 2 or more stents, and high white matter change burden. So again, we repeat, the predictors for worse outcome after stenting is age over 70, stenting within 7 to 14 days, plaque length over 13 mm, sequential or remote lesion, open cell stents needing 2 or more stents, high white matter change burden. In recently symptomatic patients, carotid endarterectomy is safer than stenting in the perioperative period, especially in the first 7 to 14 days and especially in patients over 70. Stenting becomes, CAS becomes acceptable. CAS becomes acceptable mainly in carefully selected patients. Now, near occlusion, this is a classic important thing for symptomatic patients with carotid near occlusion and distal vessel collapse. Carotid endarterectomy and carotid artery stents are not recommended unless in a randomized trial. If patient has recurrent carotid and territory symptoms despite best medical therapy, then endarterectomy or stenting may be considered after MDT review. So near occlusion with collapse, usually no intervention and recurrent symptoms, MDT only expectation. Now, free-floating thrombus, this is one of the important topic. Elongated thrombus attached to the arterial wall with circumferential blood flow distally, reported in about 1.3% of ischemia or stroke patients, often associated with atherosclerotic plaque. Almost half may have hypocoagulable state. I'm just going back again. Near occlusion. This is again an important topic for you to remember. For symptomatic patients with carotid near occlusion and distal vessel collapse, endarterectomy and stenting are not recommended unless in randomized trial. If the patient has recurrent carotid territory symptoms despite best medical therapy, then endarterectomy or stenting may be considered only after MDT review. Near occlusion with collapse, usually no intervention, recurrent symptoms, then you go for MDT to discuss. What about free-floating thrombus? This is one of the major new sections. Definition: elongated thrombus attached to the arterial wall with circumferential blood flow distally, reported in about 1.3% ischemic stroke patients, often associated with atherosclerotic plaque, and almost half may have hypercoagulable state. The key recommendation is therapeutic anticoagulation. If recurrent symptoms despite therapeutic anticoagulation, then surgical or endovascular removal may be considered. Important: do not do intravenous thrombolysis. So intravenous thrombolysis is not recommended in recent carotid territory symptoms with free-floating thrombus. What about carotid web? If a symptomatic patient has a carotid web and no other stroke cause is found, after detailed neurovascular workup, endarterectomy or stenting may be considered to prevent recurrent stroke. This matches that we already know from the textbook chapter that symptomatic carotid web has a high recurrence risk with medical therapy alone. What about coils, kings, or loops? About 13.5% patients in duplex studies had coils or kings or loops. Half had histology consistent with fibromuscular dysplasia. And the recommendation, if asymptomatic and isolated, do not operate. If symptomatic and isolated, surgery may be considered, but only after MDT review and after excluding other causes of TIA or stroke. Now, symptomatic carotid stenosis plus atrial fibrillation. This is highly exam relevant because it creates diagnostic uncertainty. If patient has TIA or minor stroke, AF newly diagnosed or already known, and ipsilateral 50 to 99% carotid stenosis, then they should undergo comprehensive neurovascular workup and MDT review to decide whether the likely culprit is the carotid lesion needing urgent revascularization or atrial fibrillation requiring anticoagulation alone. So AF plus carotid stenosis is an MDT diagnosis problem, not an automatic endarterectomy. Thank you very much. We are at the end of this episode. This is one of the most important chapters in vascular surgery, and if you can explain this in a structured way, you will be very strong in the exam. Thanks for listening to Proximal Control Vascular Surgery Exam Prep. If you have found this useful, stay tuned, because in the next episode we will continue building more on carotid disease, carotid endarterectomy and stenting procedure, carotid dissection, carotid body tumor, which are really high yield topic for the exam. We will talk about important anatomy, management and complications tied back to guidelines, evidence, and we will practice relevant rapid-fire questions. As always, with your support, we will grow together. Keep listening to Proximal Control, because in vascular surgery, control is everything.